let's go back to bulk flow again. Flow is equal to the difference in pressure over resistance. Now I'm going to swear again. Algebra tells us that we can rearrange this equation. Instead of having it flow equals difference in pressure over resistance, we could say the difference in pressure is equal to flow times the resistance. Right? That's the same equation. And we can then take a look at that equation and say, look, if it's the difference in pressure equals flow times resistance, the difference in pressure in the system would be the mean arterial pressure minus the zero that's late vena cava, right? So that's going to be the difference in pressure in the whole system from the aorta all the way back to the late vena cava, which is essentially zero. So I can hopefully change that just to MAP, right? MAP minus zero is there. The flow in the system, we've talked about where the flow comes from. We call that the cardiac output. We also use that symbol Q. And the resistance is going to be the total peripheral resistance in the system, mostly due to the arterioles. So we've made a new equation for ourselves that, again, we would never put numbers in, but we're going to say that MAP is equal to the flow, Q, cardiac output, times the total peripheral resistance. We'll stop there. On Wednesday, we'll talk more about this. We'll talk about some abnormalities as well. Bulk flow is that flow equals the difference in pressure over resistance. We rearranged the formula just using simple algebra, and we said, well, it's also flow times rate equals the difference in pressure. And then I went in and I said, let's substitute some of these cardiovascular values for our little formula there. And we said the difference in pressure in the system is really the difference between the pressure at the aorta and late vena cava pressure. Well, late vena cava pressure, we learned, is close to zero. The aortic pressure that we're really interested in is the mean arterial pressure. And so mean arterial pressure minus zero is mean arterial pressure. So we can change the delta P into mean arterial pressure. The flow in the system is the cardiac output. It's Q, right? That's the flow. And then the resistance in the system is something that we call total peripheral resistance, and that's the resistance that's going to come from the arterioles. So we've now rearranged our equation, and we've said that the mean arterial pressure is equal to the cardiac output times total peripheral resistance. And I mentioned to you at the time, we're never going to try to put numbers in here. This is for concept, right? For us to try to understand what's going on. So we've got MAP equals Q times total peripheral resistance. Let's see if we can do this with a concept. Do you remember when we did the cardiac cycle, I said this was for the systemic circuit, the left side of the heart, but the pulmonary circuit we said does exactly the same thing. I mean, I barely mentioned that it's at a lower pressure, right? So let's see if we can use this to help us understand that. So we know that the mean arterial pressure is lower in the pulmonary circuit. What do we know about Q in the peripheral or in the pulmonary circuit compared to the systemic circuit? Same, greater, equal, or less? It's the same, right? We learned that already, that the cardiac output in the left heart is the same as the right heart. So we know that's no difference. And so if the mean arterial pressure is the same, and, excuse me, if the Q is the same and the mean arterial pressure is lower in the pulmonary circuit, what can we conclude about the total peripheral resistance in the pulmonary circuit?
It's greater.
It has to be lesser, right?
Oh, lesser.
Because we're going to multiply it by, right? Q is going to be multiplied by something that's lesser or give us something that's lesser. So again, we can use this to help us understand the concepts, right? It's not to put numbers in, it's to try to get an understanding of if one thing changes, how does it affect the others. We started a little bit on this tank model, and a tank model can kind of put these three things together in another way that help us understand. I talked about this a little before. So Q is the source of blood going into our tank, the arteries. The mean arterial pressure is represented by the fluid in the tank. And then these are the arterioles that are coming out, and they're creating the total peripheral resistance, most of it anyway. So we can just look at this and say, well, if we keep the peripheral resistance the same and Q goes up, what's going to happen to the mean arterial pressure? It'll go up, right? If we leave Q the same and we lower the peripheral resistance, open up those arterioles, what's going to happen to the pressure? It'll go down, right? So this tank model can kind of help us understand how these three things are linked, how the Q is linked to the peripheral resistance and linked to the mean arterial pressure. So what are the factors that influence the mean arterial pressure? One of the factors is something we talked about before, autoregulation. And so we talked about autoregulation and we said that we could have reactive hyperemia, active hyperemia, right? Long-term autoregulation, release of chemicals. These things can affect mean arterial pressure if they're body-wide. So if all of a sudden you had the release of histamine body-wide, which opened up lots and lots of arterioles, then of course mean arterial pressure would lower. So autoregulation, these local effects can affect our mean arterial pressure. Much more important, of course, would be our autonomic nervous system. And we know that the sympathetic nervous system can change both the stroke volume and the heart rate, and it can change the size of the arterioles, right? It can cause arterial constriction. The parasympathetic, we know, can slow the heart rate. It doesn't have any effect on stroke volume, but it doesn't really have any effect on the total peripheral resistance because it doesn't affect the arterioles. But it could affect the Q, right, by lowering the heart rate. When we were talking about the sympathetic and parasympathetic effects on the heart, we didn't really talk about what the receptors were. What kind of feedback is the autonomic nervous system getting to regulate these things? And it turns out we have two major transducers, if you will, right, that can sense changes in the cardiovascular system. One of them, one type, is something that we call baroreceptors. Those of you who have lab, you got to read a barometer. What were you reading on there?
Pressure.
Pressure. So a baroreceptor measures pressure. In your aorta and in your carotid arteries, you have these specialized receptors that are sensitive to pressure. And they are sensitive to pressure. This diagram is trying to show you that, right, in the aorta and in the carotid arteries, right up here, you have these baroreceptors. So if pressure goes up, if all of a sudden the mean arterial pressure starts to go up in the aorta and in the carotid arteries, impulses will be sent to the medulla and tell the medulla, hey, lower the pressure back down, right? Pressure's getting too high. On the other hand, if less pressure was occurring, blood pressure is dropping, these baroreceptors send less impulses to the medulla, and what's the medulla going to say? Speed it up. We need more pressure, right? Constrict the arterioles, increase the heart rate, increase the stroke volume, right? Let's bring that mean arterial pressure back up. So we have these baroreceptors. We also have receptors for oxygen and for hydrogen ion, the chemoreceptors. Okay? So chemoreceptors, again, in the aorta and in the carotid arteries, they're sensitive to oxygen levels and they're sensitive to pH, to the hydrogen ion concentration. If oxygen levels start to drop, what do you think the medulla is going to do? O2 levels are dropping. Let's bring blood pressure back up, right? Let's get the heart going. Let's constrict vessels. And if pH starts to drop, that is hydrogen ion is increasing because pH, right, is lower pH means more acid. The same thing would happen. As hydrogen ion levels go up, the medulla says, hey, this is not good. We better increase the blood flow to the tissues to try to get rid of the CO2 that's responsible for hydrogen ion. And that'll make more sense after we use respiration. Another factor in the regulation of mean arterial pressure is something that we call capillary fluid shift. Okay? Capillary fluid shift. So on Monday, we looked at a model of a capillary, and we showed that there was capillary hydrostatic pressure, right? There was tissue hydrostatic pressure and osmotic pressures. If your blood pressure goes up, fluid tends to go out into the tissues. If blood pressure is dropping, what do you think is going to happen to fluid? It's going to pull it back in by osmosis, right? So we call this capillary fluid shift. If all of a sudden you go, if you go and donate a unit of blood, the volume of blood is going to go down, blood pressure is going to go down, and it's going to affect the capillaries, causing fluid to be pulled back from the tissues to try to expand the volume and bring pressure back up. It's just physics, right? This is just a physical effect. It's not really a regulatory mechanism, it just has an effect because more pressure, fluid goes out. Less pressure, fluid comes back in. We call that capillary fluid shift. And then your kidneys are involved in regulating mean arterial pressure. And we looked at this a little bit already when we did the endocrine system, but we want to look at it in more detail now. At least I want you to look at it in more detail. Maybe you don't want to, but I want you to. So we talked about part of this loop before. We know that ischemic kidneys produce renin, and we said renin then caused the formation of angiotensin. What we didn't learn before is that the precursor for angiotensin is already in your plasma, and it's called Angiotensinogen. We know about ogens, right? These are precursors. So already in your plasma, you have Angiotensinogen, and when renin is released from an ischemic kidney, it converts Angiotensinogen into something called Angiotensin 1, a hormone. Okay? Angiotensin 1. But Angiotensin 1 isn't the active form of the hormone. It needs to be converted into Angiotensin 2, the active form of the hormone, and that occurs because there's an enzyme primarily in our lungs called angiotensin converting enzyme, also known as ACE. Some of you somewhere may have heard of drugs that are ACE inhibitors. Heard those terms? Okay. ACE inhibitors, of course, would block angiotensin converting enzyme.
Do they open up the bronchioles?
Nope, they don't have an effect on bronchioles. These are going to cause dilation of blood vessels. Or not dilation, excuse me, constriction of blood vessels. Angiotensin 2, once it's formed, has two effects. One of them we know about already. This is the effect that we talked about before. Angiotensin 2 stimulates the adrenal cortex to produce aldosterone, and we know that aldosterone increases sodium retention in the kidney. Water follows, that increases blood volume, and we relieve the ischemia. There's another effect of angiotensin 2. It causes vasoconstriction. Okay? It causes vasoconstriction. So again, think about the problem. The problem is that the kidneys aren't getting enough blood. We can bring back more salt and more water to increase volume, but we can also start to constrict the arterioles. And if we constrict the arterioles, mean arterial pressure will go up. And if mean arterial pressure goes up, more flow will come to those kidneys. Okay? All right. Some cardiovascular abnormalities, some things that can go wrong with the cardiovascular system. We'll hit some of the major ones here, kind of the obvious ones. Hypertension, high blood pressure. Okay? Hypertension is high blood pressure. And we define hypertension as being, the borderline values are systolic 140 to 150, diastolic 90 to 100. That puts us at the borderline above that, right? We would say the person has hypertension. It's been probably 4 or 5 years ago. The American Heart Association came out and said, you know, we really need to watch this hypertension even more closely. And so we're going to say that anybody that has values above 120 or above 80, and of course less than the borderline values, we're going to call them pre-hypertensive. So all of a sudden, a whole bunch of people got put into the pre-hypertensive category. Hypertension's a silent disease. I'm having trouble with my pointer today. It's a silent disease. You can't feel the high blood pressure. Sometimes if it gets really, really high, people can start to have headaches and problems, but generally speaking, you can't feel when you have high blood pressure. So it's a silent disease. That's why every time you show up at the doctor's office, what do? They slap a sphygmomanometer on you and they take your blood pressure. Because you can't feel it, they want to make sure that you are not developing high blood pressure. Well, what's the big deal? Who cares, right? Well, there's lots of things that happen if you have high blood pressure. You're going to damage the blood vessels. Okay? And we're going to find in a few minutes that that increases your risk of atherosclerosis. You put excessive load on the heart and you can damage the kidneys. So damage blood vessels, excessive load on the heart, damage your kidneys. You increase the risk of aneurysm, right? That high pressure could cause the blood vessel to blow out. Not unlike putting too much air pressure in your tire in your car, which you could cause a blowout, right? Because it's too high. Most causes of hypertension are unknown. Okay? So we don't know why some people develop hypertension and other people don't. You know, if you think about it for a minute, we know that there are baroreceptors, and the baroreceptors are supposed to say, blood pressure is getting too high, tone it down, right? Bring it down, but for some reason, it doesn't happen. There certainly are genetic factors. We know lack of exercise contributes. We know that being overweight contributes. We know that excessive salt intake contributes. So all of those are factors that affect it, but we don't really know why, in general, people develop hypertension and others don't. So if somebody has hypertension, if we can get them to lose weight, that helps. Okay, so weight loss helps. Exercise can help. And then we can give them medications to lower the blood pressure. Medications include ACE inhibitors. Now, would that make sense that an ACE inhibitor would lower blood pressure? Right? We just looked and we saw that the conversion of angiotensin 1 to angiotensin 2 is what causes vasoconstriction of blood vessels, angiotensin 2, and more sodium and water retention, right? So if we stop that, we can lower blood pressure.
What is ACE again?
Angiotensin converting enzyme. We can use calcium channel blockers. It turns out that in smooth muscle, the calcium comes from outside the cell. Calcium channel blockers will cause the blood vessels to dilate. Okay, that'll lower blood pressure. Beta blockers, well, we talked about beta receptors way back, seems like ages ago, but we know that beta blockers then would stop the effect of the sympathetic nervous system. And then we can give people diuretics. And diuretics, of course, increase the loss of fluid, lowering blood volume, lowering blood pressure.
You said sympathetic nervous system? The beta blocker
Affects the sympathetic nervous system. Aneurysms, I mentioned a little bit already. You can develop a weak spot in a blood vessel. It balloons and possibly bursts. Sometimes this is something that's congenital, so you inherited it. Sometimes it's due to excessive blood pressure or atherosclerosis. So let's talk now about atherosclerosis, the #1 killer in the U.S. #1 killer in the U.S. So people think about cancer and all, automobile accidents, AIDS, all these kinds of things. The reality is the #1 killer in the United States is atherosclerosis. About 500,000 people a year die of atherosclerosis. So we should probably spend some time talking about the disease that will probably kill you. Right? So we want to talk about this disease and see what kinds of things you can do to prevent it or at least slow it. When we look at what's occurring in atherosclerosis, oh, by the way, it's a type of arterial sclerosis. It means hardening of the arteries, right? Arterial, but athero means fatty deposits in the arteries. So if we look at this, it's trying to show you that here's an artery that's nicely widely open, but it has got some damage in it. We find that the cholesterol, a particular type of cholesterol, moves into the wall of the vessel. And the type of cholesterol that moves into there we call low-density lipoprotein. So the LDL cholesterol moves into the vessel, into the wall of the vessel. Once it moves in, macrophages follow the LDL. The LDL oxidizes. The macrophages eat the LDL, and they become something that we call foam cells. So they're trying to show these cells are swelling up in there, and as they start to swell up, they push out on the wall of the artery, and as they push out on that wall of that artery, the artery wall becomes irritated. The body tries to cap that off. So here's another picture that can show us this. So this is trying to show, again, it's hard to see, but it's trying to show that the LDL is moving into the wall. There are specialized receptors on the wall of our arteries that allow LDL to move in. They get eaten up by the macrophages, forming these foam cells. The foam cells are in here, and they're causing inflammation of that vessel. We're going to form a fibrous cap over this area. Eventually, calcium can deposit in there. And eventually, due to just really the kind of the rubbing of the blood against that fibrous cap, the cap can rupture, and we're going to form a thrombus. We know, right, that if you expose collagen that's underneath the blood vessel, that platelets will begin to adhere to form a clot, and now you've blocked the flow of blood.
Is this caused by diet or stress?
We're going to look at risk factors in a minute.
How are they getting the calcium thing? Calcium is covering over the capsule, so how are the blood vessels running into the cholesterol? To the collagen, I mean.
Yeah, so once it ruptures, that's when they're going to. So the inflammation eventually causes that to rupture.
Okay.
Think of pulling the scab off, if you will.
All right.
And that's when we're going to get exposure.
When you're saying that it calcifies, does it get like hard as bone kind of?
It can. Doesn't always. So atherosclerosis is a type of arteriosclerosis. So the first phase is just to get fatty deposits, but eventually calcium deposits. And yes, you can feel the calcium. So I don't know if you guys have had a chance in, like when you had anatomy, but you know, I used to always, when I would teach anatomy, when we'd have a heart there, I usually could find some places that have calcified, and you could just run your fingers along, and you would feel the nice hard calcium. Did you guys get to do this? Yeah. So I mean, you could feel the calcium in those vessels. Commonly, before the actual clot occurs, because the blood vessel has lost its ability to transport blood, right? The volume in there has shrunk. The area beyond that becomes ischemic. If that's occurring in your chest, we say that the person has angina pectoris. I know that the general population says angina, but cardiologists say angina, so you will say angina rather than angina. Right? So it simply means that the person is experiencing chest pain, okay? Angina. It may mean, if it's very severe, it may mean that the person is actually having a myocardial infarction. But it can also just be that they have low blood flow, and so they're experiencing angina. If this is occurring in the brain, then the person may have a stroke, right? So the blockage occurs and not enough blood is able to go to the brain. Not that you need to know this percentage, but about 80% of strokes are due to thrombi. The other 20% are actually due to rupturing. Okay.
That's with the carotid arteries. That's what gets clogged.
Very common, the carotid artery, places where there's a lot of pressure. So the carotid arteries, femoral arteries, common iliac. I mean, this could happen anywhere. So what are the risk factors for developing atherosclerosis, right? It'd be nice to know what these risk factors are. We have 3 columns up here. The first one, major risk factors that cannot be changed. So these are things that are risk factors, but we can't change them. First one on the list, heredity. You can't change who your parents are, right? They are who they are. You got your genes, and that we know is a risk factor. If your father developed coronary artery disease less than the age of 55, or your mother less than the age of 65, we know that you are increased risk. Okay? So heredity is a factor. Sex is a factor. Males are at higher risk than females. Huh? So males are at higher risk than females. Race is a factor. We know that some races have higher risk than other races. For instance, we know that people of African descent are at higher risk than Caucasians. And age is a factor. You can't change, I guess you could change your sex, but, right? But you can't change these other things. So age is a factor. We know that as you get older, your risk increases. So for men over the age of 45 and women over the age of 55, those are increased risk factors. All right, so there's nothing we can really do about that first column. Let's look at this column. Major risk factors that can be changed. Number one on our list, cigarette smoking. Our next topic is going to be respiration, and cigarette smokers usually figure they're going to die from smoking. It happens. They get lung cancer, they get emphysema. But the number one killer of cigarette smokers, folks, isn't emphysema and lung cancer. It's atherosclerosis, right? They get a much higher risk, they're at much higher risk of developing atherosclerosis than the normal population. We don't know why. There are some chemicals that are in tobacco that stimulate atherosclerosis. Alice, you had a question?
Is it just nicotine in general, or is it smoking?
Is it just nicotine in general? So I'm assuming you're talking about marijuana then, right?
Somebody can have tobacco.
Yeah, chewing.
Yeah, so marijuana doesn't seem to convey the same risk as the nicotine in cigarette smoking for causing atherosclerosis. All right, that one's fairly straightforward. Hypertension. We know that people that have hypertension are at increased risk of developing atherosclerosis. Running the high pressure constantly through the blood vessels irritates the wall of the vessels and increases the likelihood that they're going to develop atherosclerosis. How do we change that? We get them to control their hypertension, right? So either through diet, exercise, drugs, we control the hypertension. Blood cholesterol is a factor. We know that people that have very high levels of blood cholesterol are at increased risk for developing atherosclerosis, particularly if they have LDLs that are high. Okay? So high LDLs. You know probably from somewhere there's a cholesterol that actually is good for you, and we call that cholesterol HDL, high density lipoprotein. We consider that a good cholesterol because its job is to pick up cholesterol that's out in the tissues and vessels and bring it back to the liver to be removed from the body. You will always have more LDL than HDL, but we like to see those HDL levels get higher and the LDL levels get lower. More than what we need to know in this class, but we like to have, you don't need to know this, we like to have that ratio of LDL to HDL be less than 3 to 1. And if it's greater than 5 to 1, we consider you at high risk. Erin, did you have a question?
I did. Can they test for it if someone in their 30s? Like, is this something that they can go and test for?
We can check HDL, LDL levels it's all done through blood at any age. How many of you in here know your total cholesterol value? Oh, bad show, folks. You all should know your total cholesterol value. We like to see the total cholesterol less than 200. Next time you're driving by the supermarket or the pharmacy and it has a sign out front and it says cholesterol testing today, pull in and get your cholesterol tested. Say, oh, I'm not fasting. It's okay that you're not fasting. Actually, some recent data suggests that there's really not much difference between fasting cholesterol levels and non-fasting cholesterol levels. So get your cholesterol tested. We want it less than 200. If it's above 200, then you probably should get it tested when you're fasting, and you need to let your doctor know that your cholesterol levels were high. Because we know when cholesterol levels go up, there's increased risk of developing atherosclerosis. So let's look at this just a minute. So, I know you can't read this, right? The numbers are too small, although if you go on the internet, you can take a look at this. This graph is showing the death rate per 100,000 male population relative to the cholesterol intake. It's a graph from the 1950s. You say, well, why is he putting this up here? I'm putting it up here because it shows us something pretty interesting. For whatever it's worth, we've lowered the death rate from cardiovascular disease from the 1960s by half. And since 1980, we've lowered it by a third. So we've been able to bring the death rate down dramatically. This is from the 1950s. And the reason that I think this is pretty interesting is because they looked at the death rate per 100,000 and they looked at the cholesterol intake way up here. So you got to think back to 1950s, right? So your grandparents, maybe parents. Here's the United States. There's Australia. There's Canada, New Zealand. And way down here, so low death rate, low cholesterol intake, there's Greece, Portugal, Japan, right? Ceylon. So think 1950s. Diet.
No arches.
So where's the beef, right? And how about diet down here?
Fish.
Mediterranean diet, right?
Green
Fish, vegetables, olive oil. Striking, right? It's striking. Here's a study that was done on monkeys. That was, I think, is kind of interesting. So they had a control group and an experimental group of monkeys, and they had them both on a regular Purina monkey chow diet. Purina makes monkey chow. Okay? They had them on a Purina monkey chow diet, and then they put the experimental group on an egg yolk diet. Okay? So they just started feeding them egg yolks only.
Raw or
I don't remember. It's not going to matter. So if we look, this is month 1, 2, 3. Within the first month, they started to see changes in the cholesterol levels, and by 5 months, they had the first appearance of what they called xanthomas. That is, the streaking of fatty deposits in the arterioles within 5 months by feeding the monkeys an egg yolk diet. Okay, one more cholesterol on here. So here, yes.
So here's the major risk factors that can be changed. Diet, is it?
Diet's one that can be changed. So we're talking, because cholesterol is about diet, right?
Yeah.
So we know that if we get people to lower their cholesterol intake, but really more importantly, their saturated fat intake, cholesterol levels plummet.
So does that really correlate with like the obesity epidemic? I mean, I'm sure it does, but you could have high cholesterol levels and still be like...
You don't have to be overweight to have high cholesterol, right? So you could be thin and maybe you're on an egg yolk diet, right? I had a student, maybe I told you guys this already, but he was a bodybuilder and he was taking this class, and so we were talking about cholesterol and things, and he said, well, do you think 8 eggs is too many? And I said, well, you know, we usually figure about 1 egg a day, so 8 in a week is not bad. He said, no, 8 eggs a day. So he was eating 8 eggs a day as his protein source because he was into lifting weights. Really, really high levels of cholesterol coming in, right? Huge. And so another one, this simply shows the amount of cholesterol in the diet and cholesterol in the plasma, blood. And the more cholesterol you eat, the higher the cholesterol levels. Again, you can remove almost all the cholesterol from your diet, and you could still have high cholesterol levels if you're eating saturated fats, because the liver will take the saturated fats and make cholesterol. Here's a table that shows things that can increase your HDL for you. Right? So things that can increase your HDL. Black race, members of the black race have higher HDL. It kind of goes against the whole thing of that they're also at higher risk of heart disease, but we know that they have higher HDL. Females have higher HDL. The other side's the opposite each time, right? Having diets high in vegetable fats and oils tends to increase your HDL. High animal fat, right, lower. Increased physical activity increases your HDL. Being a non or ex-smoker, so surprisingly, smoking increases your LDL and lowers your HDL. Moderate alcohol intake. Students usually like seeing that one. Moderate means 1 drink per female, 2 drinks per male per day. More is not better, folks. So yeah, whoa, 6-pack a day, man.
Small drinks too.
People of normal weight have higher HDL levels versus obesity. Normal cholesterol levels. So if you have a normal cholesterol level that is less than 200, you tend to have more HDL than people that have high cholesterol levels. People that have low triglyceride levels have higher HDL levels. Normal glucose levels versus people that have diabetes. Non-coronary persons, people that have not had coronary artery disease, if we check them, tend to have more HDL than people that have had heart disease. And then children of healthy parents versus children of coronary heart disease parents. And then two kind of strange things. Certain pesticides can raise your HDL levels. Pesticide. And we know that estrogens in general increase HDL levels.
Is that like direct contact with the pesticides? Like if you're working in fields or if you buy?
Either one, direct contact or if you took it in. This is kind of a weird thing, right? They found certain pesticides raising HDL levels. You don't want to do that. We got drugs that will raise your HDL levels. Okay, diabetes is a risk factor. So people that have diabetes are at increased risk for developing atherosclerosis. It turns out that there's really a twofold thing that happens here. One, glucose moves into the wall of the blood vessels and it causes the macrophages to move in. So that's a problem. And then we know that people that have diabetes tend to have increased levels of fats in their blood because, right, their body is moving fats out of the adipose cells into the blood trying to supply energy. We know that obesity is a risk factor. People that are overweight have increased risk of developing atherosclerosis. And then finally, we know that lack of exercise is a risk factor for developing atherosclerosis. Let's look at that for a minute. Here we go again with an old graph, but it's an important graph. So this is a graph showing the physical activity index in kcal, so in calories, versus your risk of having a first heart attack. And this was done clear back in the 1970s looking at Harvard alumni. So why do we want to look at something from the 1970s?
Why would you want to look at Harvard alumni?
Yeah, it's just they happen to be a study group that they were able to get. So if we look at this for a minute, you can see this curve that shows as your physical activity index increases, your risk of having a heart attack decreases. Right? So here it shows vigorous sports, here's other activities, very similar curves, a little steeper if you have vigorous activities. And if you follow this curve, you can see the major drop occurs for that first 2,000 calories. This continues, but it kind of flattens out. So ideally what we want to do, and once this study came out, clear back in the 1970s, we said what we need to do is to get people to exercise at least 2,000 calories per week. 2,000 calories per week is quite a bit. So for an average sized woman, it means walking or running about 20 miles per week. More than what most people want to do. Okay? However, subsequent studies showed that if you can get people to burn 1,000 calories a week, they'll get the other 1,000 calories for free. What? If you could get a person to burn 1,000 calories a week, so they start some exercise regimen. It's walking, it's running, it's cycling, dancing, whatever it might be. You get them to burn 1,000 calories a week, they'll start to do other exercises and pick up the other 1,000 calories. So you've got them on a regular exercise regimen. When they show up at the supermarket and all the parking spots are filled in front of the door, what a surprise, they'll actually park at the back part of the lot and they'll walk to the door. When they come to a 2-story building, instead of pushing the button for the elevator, they'll go up the stairs. When they're at home and somebody comes by and says, I'm going for a walk, would you like to join me? They'll say, oh, okay, and they'll go for the walk. So you pick up the other 1,000 calories for free if you'll do the first 1,000 calories in a regular exercise regimen. 1,000 calories, pretty easy. So average sized woman, it means about 10 miles per week. Well, a mile a day plus a little, right? Not that hard to do. All right, so that was a pretty exciting study when they came out with that. They did a follow-up study, again looking at Harvard alumni. This one shows the physical activity index again versus the risk of having a second fatal heart attack. Okay, so they took a group that had already had one heart attack and they said, what's their risk of having a second fatal heart attack relative to the amount of exercise that they do? And if you look at this curve, you'll see it's the same curve as up there. This was a real surprise, folks, when this came out.
So if they exercise more often, they're higher risk or lower risk?
What does this show you? So here's the risk of having another heart attack. Here's the activity. So there's 100% risk of having a heart attack. If you exercise, what happens to your risk? It's dropping, 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 dropping. And it's the same curve as this one up here. I can remember being a young man, folks. My dad was a pharmacist. I worked in the pharmacy with him. And I remember heart patients in our community coming in and they say, oh yeah, I had a heart attack. Doctor says I shouldn't do anything strenuous from now on. I just need to take it easy. But that was standard care, right? Don't do anything strenuous at all because you've had a heart attack. When this study came out, they said, wait a minute, that's exactly the opposite of what we're supposed to be doing. We've got to get them exercising so that their heart gets stronger. It's like any other muscle. So now when you go to the hospital and you had your uncle or your grandfather, somebody's had a heart attack, you go to the hospital, maybe you go in their room and you think, oh geez, Uncle Jim, he's not in here. Did he die? And you ask the nurse, and no, we have him out walking the halls, right? He just had a heart attack and they got him out walking. They've done some work, recovery work, but they've got him out walking in the halls. Why? Because of this graph. Right, now, the exercise needs to be prescribed. So don't take grandpa out for a run, right, just because he had a heart attack. It needs to be prescribed by a physician. It's a gradual increase, right? We have these cardiac rehab centers, but they didn't ever have it before, right? Because they said, no, this is going to hurt them if they exercise. We need them to exercise to strengthen that heart. Yes?
You know if the same would be for like strokes and stuff?
No, this is for heart disease because we know we can get that heart stronger. I have to say I don't know for strokes. Somebody knows, I don't. Well, I'm sure studies have been done. I just don't know. So since we're doing lack of exercise, I want to do one more chart here. This is kind of an interesting chart. So this shows cardiorespiratory fitness, whether you're low on your fitness, moderate, or high. So they're testing your ability to do exercise. And this first one is looking at death per 10,000 population and the smoking status. So the back one here is smokers. The front one here is non-smokers. And if you look, they're pretty similar graphs. Right? So whether you're a smoker or a non-smoker, we know that as your cardiorespiratory fitness goes up, you decrease your risk of dying. Right? Whether you're a smoker or a non-smoker. Here's, again, same thing, cardiorespiratory fitness, death per 10,000. Here's looking at cholesterol levels, people that have high cholesterol, people that have low cholesterol. Pretty similar graph, right? Get them to exercise. This is looking at people with high blood pressure versus normal blood pressure. Exercise, right, decreases the risk. And then this one is something that they just call overall health status, which is kind of a tough one to evaluate, but even people that were unhealthy relative to people who were healthy, as they increase their exercise, their risk of dying decreased dramatically.
Except that you always have a 100% chance of dying.
Well, but it was age-related, right? Age-related, so at age 40. But yes, we're all dying. And we're all going to die of something.
From the time we're born.
From the time we're born.
Or before.
Before I leave this one, what let's do? So contributing factors, stress. We know that increased stress increases your risk of cardiovascular disease. Pretty hard to quantify, but we know that people that are under lots of stress have increased risk of developing atherosclerosis compared to people that do not have increased stress. There are other markers that they are working on trying to identify risk factors for developing atherosclerosis. Not that you need to know these folks, but they're looking at things like another lipoprotein called lipoprotein A. That seems to be linked to it. There's some recent evidence that a particular byproduct of bacteria in our gut that's called trimethylamine oxide, TMAO, increases your risk of developing atherosclerosis. The bacteria that are producing the TMAO are feeding on choline, which happens to be in lots of foods, eggs, meats, those kinds of things. So they're working on, is this a good identifier? They're trying to find other things, right, that can predict whether or not people will develop atherosclerosis.
Can they do this through blood?
It's all done through blood. So they do these blood tests, yes. And they can find that particular one, TMAO, in the blood. So what happens when a person has a myocardial infarction? When a person has a myocardial infarction, the coronary artery becomes occluded, right? It's blocked. Tissue beyond that blockage dies, and so then we say they have dead tissue, an infarct in their myocardium. In a clinic, they're never going to say myocardial infarction. They don't like saying long words. They're just going to say patient had an MI, right? It's too hard to say myocardial infarction.
And when you're talking about a coronary artery, those are the arteries that come directly from the heart, right?
Right. So there's two major coronary arteries that come right off the aorta. Right and left coronary arteries. There are further branches. So you have the left anterior descending, the circumflex. Did you guys learn those? Yeah. When a person's having a coronary artery occlusion, they're going to develop pain in their chest, so angina. They may also have it in their arm. They also may have it in their jaw, sometimes in their neck. And sometimes hardly any symptoms at all. So sometimes they just report they're feeling nauseated. Women, for some reason, seem to have less expression of these, the typical kind of symptoms than men. We don't really know why that's the case. Once we know that the person's having a heart attack, they're having an occlusion of the coronary artery, we need to get that artery open as soon as possible. That's why we need the clot busters. So that we talked about the clot busters before, right? The TPA and the streptokinase. The key here is time, because time is tissue. The longer it takes them to get into the hospital and receive a clot buster, the more tissue will die. And as I mentioned when we talked about this before, one of the real problems with myocardial infarcts is people will deny that they're having a heart attack. I say, oh, can't be me, right? And so they'll maybe put off going to the hospital for 6, 7, 8 hours. Well, now it's too late to save that tissue, right? They've lost the tissue. So get them to the hospital, let the hospital decide if they're having a heart attack. Yes, Aaron?
You said myo is dead tissue?
Myocardial means the myocardial cells. Myo means heart muscle, right? Myocardial means heart muscle. Infarct means dead tissue.
Infarction.
Right. If we know that the person has occlusion of the coronary artery, one of the things that they can do is an angioplasty. So in angioplasty, they're going to run a catheter generally up through the femoral artery, but sometimes they can also do it above the heart. They're going to go, first they're going to do an angiogram. They'll squirt a little dye into the coronary arteries and see if there's normal flow. If they can pick out a block, they can put a little tiny balloon on the end of the catheter. They go into that artery and they inflate that balloon and push the artery back open. So this would be called an angioplasty. Initially when they started doing this, it was just this tiny little balloon and nothing else. Now it's almost always done with a stent. And so this diagram's trying to show you, they have this little stent that the balloon's inside, and then this little wire basket-like structure. They inflate the balloon, it causes that stent to open up and lock in place to keep the artery open. Aaron?
Is that the same as a triple bypass surgery?
No, we're going to talk about bypass in just a second.
Okay, sorry.
So they put the stent in, it will enlarge and hold the artery open. Typically, these days, they'll coat that stent with certain drugs to stop scar tissue from forming. They also are able to now, sometimes, this is still pretty much experimental, but they can use stents that will eventually break down, so biodegradable stents. Yes?
So the stent stays there, there's no
Stent stays there.
danger of it moving out of place?
When they inflate it and keep it there, it locks in place, which is actually, if you think about it, it's pretty much an engineering miracle in terms of it's got to be tiny to get in, but when they inflate it, these little things have to lock into place so that it won't collapse. Yes, Kyle.
So if I have a heart attack, I go into the hospital, they give me a clot buster first. Then the clot is away, why would they even need to put in the balloon in?
Yeah, because that area has been, so the clot's gone now, but that area still has been partially occluded, right? Because of all those macrophages, those foam cells, the artery is closed off, and they don't want to have another myocardial infarction occur, right? So they don't want another clot. So they're going to push that open. Alex, and then we'll get
Can a stent aggravate atherosclerosis because it's rubbing again?
Yeah, it doesn't, initially when they put these in, the scar tissue would form there, but now they have drugs that are constantly released, and it doesn't. So it keeps it open and allows blood to flow nicely. Emily?
The balloon that you're showing, I feel like the catheter that's running through that is teeny. Like how?
Oh, they're tiny, 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 because
Is
they...
the blood's going through the catheter?
No, blood's not going through the catheter, so they're running that catheter up, getting through typically the femoral artery. They have to go all the way up through the vena cava. They're going to go into the, not to the vena cava, sorry. They're going to go up through the aorta. They're going to come down into the left ventricle, and then they're going to come back up the aorta, and they're going to hook it into the little openings to the coronary arteries. Then they're going to squirt dye first, and then they're going to actually run this. They're doing this all with an X-ray. They're going to run the little catheter wire down into the coronary arteries with a little balloon on the end, and then they are able to inflate this little balloon. And of course, temporarily, when they inflate it, there's no flow at all.
Yeah,
but then they're going to withdraw it, and the stent will hold it open.
Oh, okay.
So the question was about bypass surgery. So if they can't fix this with a stent, they're going to do a coronary artery bypass graft. Okay? Coronary artery bypass graft. Because they don't like saying really long words like that, right? All those words together, they're just going to say CABG times 3. Right? So this person had 3 coronary artery bypass grafts. And this diagram is trying to show you what occurs here. So here's coronary artery that's blocked with plaque. They'll take a vein, very commonly from the leg, the saphenous vein. They'll harvest that, so they'll tie it off at the top and the bottom, cut the vein out, and then they tie that. So this is generally done by cracking the chest, opening up the chest, although they are starting to do this through little ports. They open up the chest. The person has to be on a heart-lung machine. They're going to tie the vein to the aorta and then go around the blockage and tie it again below. So it bypasses the blockage and allows blood to flow from the aorta directly down to the rest of the coronary artery and allows normal blood flow. Sometimes they're able to use the internal mammary artery, and so they don't have to actually harvest a vein from the leg. Then they simply take the internal mammary artery off the chest wall and they use it to run beyond the place where the occlusion occurred. They are doing some robotic work now where they're able to make portholes into the chest, place the device on the heart, and it's actually able to take into account the fact that the heart's beating. And they're able to tie these little bypasses in place while the heart's beating, which is amazing, right? But it saves the person having to have their chest cracked open, helps dramatically in terms of recovery period. Okay, hemorrhage and hypotension. Hemorrhage and hypotension. So what if you hemorrhage and you lose a lot of blood? If that happens, blood pressure is going to drop. And this looks like a pretty complicated chart until you realize we pretty much have gone over everything.